So welcome. You have me today. Jessica is out of the office today, so I am hosting. I'm Jennifer Akers. I'm the grants manager for the pilot project grants. And these are funded by the American Rescue Plan Act. So we've been doing a series of these. We're about, I think this takes us into over halfway through. They are being recorded, so they're going to be available on the website I'm going to show you in a couple of seconds. And there's actually a playlist on the FSSA YouTube channel. So if you want to revisit any of these, it is possible to do that. And we're going to post the slides as well. So we just wanted to give you a little bit more information about this in case this is the first one that you've joined. These projects fall into general categories because they were given some directive about what we were hoping to accomplish with the pilot projects. So some of them are around supporting those that support, who could be the DSPs, could be caregivers, paid caregivers or unpaid caregivers, support through technology, which we have one of those today with telehealth, community partnerships and community change, information and skills for individuals. We have some projects that are offering music therapy or the peers social skills curriculum and different things for individuals themselves. And then we have several today that are exploring current models of service definitions and payment. So all of these are going to inform the state about things that we might want to do going forward. So over the next 2 years, we have this great opportunity to actually try some things and see how they work. That's not something we typically get to do, and go ahead and get some information about these. So there are also one pagers on this website. If I can get into the chat, or if Alina can do it for me, we can put in that link at the bottom, since it's not clickable when it's a PowerPoint, but there is a website now dedicated to the innovative pilot projects. I just have a screenshot here, but if you scroll down to the bottom, they all have a one pager, which is certainly not enough to cover their whole entire project, but it kind of compares them apples to apples, so you know where to find everything on the page. And then at the very bottom of that, the beginning of the recordings have posted. So as I get them to communications and they get them uploaded, I think 3 of them are there. We're up to 6 now, so I'll get the rest of them to communications and get those uploaded. So if you're looking for more information about these pilot projects, you want to see what some of the other topics are, this is a chance for you to get more information about them. So today we're going to hear from Insight/ViaQuest, Kestrel Behavioral Health, StationMD, and Optimal Access. So we will go ahead and start with Kelly, and I will be your Vanna.
Thank you, Vanna. First of all, and I know that everybody will say this, but from our hearts, the commitment that BDDS has to, and really all the stakeholders involved with IPP grant initiatives, we want to thank everybody. We really believe this collective effort is going to help move the needle towards the needed culture change that's going to support all people, not just the people we support, but the people who support those people towards living their good life. So this presentation will probably scare about 600 to 700 behavioral consultants across the state. So it's a bit of a behemoth project, but I'm happy to answer questions at the end of the webinar today. We are looking at redesigning behavioral supports. And this is done in a partnership between Insights, ViaQuest Community Solutions, and Opportunities for Positive Growth. And between those two organizations, we have over 100 behavioral consultants who have been and continue to work across the state in HCBS services. Go ahead and advance the slide, Vanna. So I've tried to keep this pretty simple. Vanna, there you go. We've identified the problem. We feel like, a whole lot of folks in the system are still really struggling on their trajectory towards a good life because they continue to experience significant behavioral challenges. And so in choosing a behavioral supports provider, they're not able to get their needs met for a number of different reasons. One, there's a lack of qualified professionals. We don't really feel like just getting a certain degree or a license qualifies you to do this work. We feel like there are BCs who really feel limited by the one-to-one service delivery because sometimes group options might be more effective to meet an individual's needs. We have difficulty finding individuals have difficulty finding clinicians that really have the expertise to meet specific needs, whether that's diagnostic or an assessment, from an assessment perspective. Um, there tends to be a bit of a myth, I think, or a flaw in service design as it exists, that there's a belief that behavior management goes on forever. And that really is not necessarily what all individuals that need behavior management services need. And so we're going to really look at that in our project. And really the historical practice of one size fits all in behavioral supports is a challenge, and we've identified that as a problem really since 1995, when we really started getting into providing behavioral supports and HCBS services. There hasn't been a lot of changes. So we have all BCs are reimbursed to do all of the services, and it's sort of a one size fits all perspective. You can advance the slide, Jen. So those are the identified problems. The contributing factors really are that the system has grown a great deal since the mid-90s, but we haven't really changed the structure, expectations, or service delivery methods whatsoever. The number of people and services, as well as the clinicians providing support, has grown exponentially since the beginning of the waiver system. We've led, right now, we're at about an annual current expenditure of more than $85 million on behavioral supports, which represents about 9% of the total spend in waiver services. But I don't feel like a lot of folks feel like we're getting the quality we should for that expenditure. Just to give you a perspective, in October 2013, I was able to dig a report out of my drawer because I don't throw anything away. We had 15,551 people in waiver services, but as of today, we have more than 32,000. So the system has more than doubled just in 10 years, but we haven't really made changes in the system that have been sustainable for quality. Indiana's current clinical workforce hasn't really integrated over that time a lot of the newer best practices. There have been so many evidence-based initiatives and approaches that have been advanced over the course of the last 20 years that we really haven't integrated into our service design. Things especially like how to use psychoeducation to work with our folks, looking at the advances in neuropsychology and how that should really impact our assessment. Trauma-informed care is a really, really big body of evidence that we need to integrate into our practice. And we just feel like those things need to be part of our common language and approach instead of things that are happening out there and not integrated into Indiana service delivery. The other challenge and contributing factor to why we have the problem is that our current service definition almost lends itself to unnecessary services. As a BC, if I take over for someone who might have worked with an individual for the past year, I shouldn't be billing to redo the entire functional behavior assessment and the entire behavior support plan and redesign everything about that. But right now, the service delivery system kind of dictates that some of that happens. So I think that we need to really look at those system changes. And so insights, ViQuest Community Solutions and Opportunities for Positive Growth have really identified some solutions that we would like to explore. Some of these are best practices that are being used in other states, and we're super excited to test over the next year with folks in Indiana. Next slide, Vanna. We're going to look, number one, at a tiered service delivery structure with tiered reimbursement. Since the mid-90s, we've had one size fits all. We feel like more highly skilled clinicians should be doing the more complex clinical activities for folks who really need that, and that maybe newer BCs or less qualified clinicians could be doing the follow along and coaching with appropriate supervision. They're doing this in several states, and we'd like to try that out in Indiana. We believe there should be a foundational curriculum for all behavior management providers as a requirement that would empower some common language for best practices. That way our entire workforce also has some common language around how to do behavioral supports and how to implement changes in people's lives. The third solution we'd like to explore is introducing group behavioral support offerings. So think of, like we do with rehabilitation services, people would be in ratio for specific like psychoeducational groups or behavior change outcomes in small or larger groups. And the last thing is when we get to test these, it would obviously lead to some new service definitions. You can advance the slide, Jen. So our strategies to get there, right now we're in a phase of collecting data from across the country as well as within our state, looking at how the existing tiered service delivery and methodology could be implemented. Several states are doing this and doing it very well. And so that is one of the strategies that we're doing now to get to the next steps. We're going to introduce existing BCs to a best practices curriculum that we can then, as a focus group, sort of Indiana-atize and make that a way to empower common language and a minimum set of competencies for all clinicians statewide. The third thing we're going to explore is group options and measure the effectiveness of that. So think of a 6-session group with a larger 6 to 10 individuals in service. And what we would do is incorporate and pay co-facilitators who have lived experience. An example would be to teach life course and how that impacts behavioral supports and outcomes. But in that, we would have a co-facilitator of a life course ambassador who is a person with lived experience who's in services and has experienced many of these concepts in their own life. That would be for 6 sessions, and that's for groups of 6 to 10 people with a behavioral consultant and a co-facilitator. And then the second little like mini groups would be more like 3 sessions, small groups with 3 to 5 people. And think about these things like when roommates need some challenges worked out within their home, or you have a loss of staff and people are grieving that. Perhaps a group at day services needs a little help with just building relationship skills. Those are the kinds of things we would do in the mini groups. So we're going to test this across different areas of the state, different kinds of providers, and then collect data on the effectiveness of that. And the last thing, obviously, is after we collect all this data, we want to make sure that we involve all stakeholders, and that would guide our strategies, measure the effectiveness of what we've tested, and really hope to achieve better outcomes. Next slide. So please keep in mind, this is a huge undertaking. We have no idea if this is going to be great or not, but it is things that are being done across this country that have led to better outcomes than we're able to achieve with what we're spending in Indiana. So we really want to look at what concepts can we prove to be effective and how does that look in foundation for redesign. What we're hoping to do with this project is increase outcomes of quality for people to achieve that trajectory towards their good life. Really look at the quality and consistency of clinicians and the expectation across the state, and then hopefully achieve some efficiencies in the expenditure of waiver dollars. I feel like $85 million is a lot of money. Spending 8 or 9% of the total waiver budget, we should be getting greater outcomes for individuals. And hopefully some of these concepts will get us there, or at least prove that we can't get there that way. So we're excited about the next steps. Next slide, Jen. So I realize people will have questions about all of these presentations. We've left our emails in there. Feel free to reach out to any of us that are running point on this project, or you can scan this QR code and get regular updates from our group, including participation opportunities as far as stakeholder surveys, being a part of group, having your agency involved specifically. And we would like for you to share this information as well with the people that you support. So we're super excited. I don't know how long I went, but I felt like I talked fast enough. Jen, I'm all done.
Thank you, Kelly. You did do an awesome job staying in within your time frame.
Thank you very much.
And your QR code has me very envious of your tech skills. So,
I didn't do it.
okay, we'll go ahead and move on to Kestrel. Jim and Brian, you both can control your video and your audio. Kelly, if you want to go ahead and mute, and then I will be your Vanna.
Okay, so my tech skills are probably not the best among people here. So this is us. We're doing something that I think is it's not the same stuff that Kelly's group is doing, but I think it folds nicely. It's very complementary. We both have decided, and we're going to be working together because I think these are very complementary goals. Both are also about improving quality and behavior supports. So our project is a little bit less extensive. It's more of kind of the small bite of the apple, where we are trying to improve level 1 supervision. So next slide, please. All right, so just a brief introduction of who we are. Kestrel Behavioral Health started in 2010. Last year, we rebranded and became an LLC, and we reapplied with BDDS and really started to provide more supports. We specialize in both the level 1 and level 2 behavior supports. I'm a psychologist with endorsement as an HSPP, which allows me to do level 1. Brian has many years as a BC, and he's a licensed mental health counselor. And we're the two partners. We also have employees. We're the two who are going to be spearheading this project. We also, you know, I put this last bullet point on there to kind of indicate we're trying to be, you know, good corporate citizens, members. Somebody lost audio. Are you able to hear me, Jennifer?
I can hear you.
Okay. I just saw that text that somebody lost audio. So in any case, we're members of INARF, Indiana ABC, the Indiana Psychological Association, as well as the National Association on Dual Diagnosis. And we decided we wanted to cast a wide net and kind of be part of the greater provider community and try to be able to be up on the latest. And you know, I like I mentioned earlier, I think that Kelly's project, I know it's more than just Kelly's, it's Insights via Quest as well as OPG. We're really interested in participating in that. I just actually took the picture of the QR code so that we can get on that list. So I encourage everyone to do that. And you'll be hearing from us too, because there are a few components of our program that we're going to be reaching out to other providers too. So next slide, please. So what are we trying to do? In a nutshell, we're really trying to look at Indiana's level 1 supervision, which is in code, it's in the waiver manual. We're trying to improve it because we think that right now its provision is pretty uneven. This waiver support started in 2001. It was part of the waiver manual then, and really not too much has changed since then, also including the rate. Which I think has also presented challenges, but that's not nearly the biggest challenge. You know, so for example, in the Indiana Administrative Code, level 1 is required for every behavior support plan. Beyond that, you know, it basically says an HSPP endorsed psychologist has to supervise behavior support and approve behavior support plans, but it doesn't specify really how that happens. In the waiver manual, there's really only one sentence dedicated to level 1 support, and really all it says is that an HSPP psychologist cannot provide both level 1 and level 2 at the same time. It doesn't give any details as far as like what are service standards, what's prohibited, you know, and so as a result, there are some providers out there that do pretty high quality level 1 support where they meet with clinicians, and there's some people who send BSPs in an envelope and get them back signed. So there just is it's a very wide disparity, and really the end result is it impacts quality, and it has nothing to do with client acuity. It has nothing to do with client need. Really, mostly it has to do with what does the provider of behavior supports, what investment do they have in the process? And some just want to do away with it. We decided that we thought that maybe a better option, instead of just saying that it's not working very effectively across the state, is let's learn more about what is happening and then try to help BDDS improve what needs to happen. So I did include on this last bullet point that the reimbursement is low. It's the same exact reimbursement as for level 2 behavior support. And as a result of that, I think it's safe to say not terribly many psychologists are very interested in providing this support. So even if we improved the quality of the code and all that kind of thing, it'd be very hard to recruit providers. And that's also part of our project is exploring that and also recruiting and training providers. So next slide, please. Brian, I think this one's on you. So take it away.
Yeah, I'll take over here. Thanks, Jim. Yeah, so in line with our goal to look at, what is quality supervision, what is high quality supervision versus low quality supervision, and just, again, using quality as a metric. We have this chart here to kind of compare. So on the left column, we see high quality involves a level 1 supervisor working directly with the BC, whether that be in-person meetings or virtual, just having an opportunity to have some dialogue about the behavior support plans, an opportunity to ask questions, get feedback, and really have a conversation about how that individual is doing and what supports could be tailored to their needs specifically, and then reflected in the plan. And we feel like that setting improves just the whole learning process for the supervisee. And there's a ton of research on clinical supervision to support that. And it's also prioritizing like high acuity behavior. So if you have an individual receiving services who's just not having a good time, is really having some behavioral challenges, you might spend more time talking about that individual. Whereas a person who doesn't have as many high behavioral needs, you might spend less time talking about that plan. If we're to compare that to low quality supervision in the right column there, it's a blanket supervisor might receive the plans and spend all the time reading the plans, not really focusing on like who would need that support. So and there's also not an opportunity for feedback if a level 1 supervisor is just receiving the plans via email or snail mail and reading them and sending them back with a signature. So and if you advance the slide, Jennifer, so we see that both of these scenarios currently meet the 460 code. And again, it just kind of reinforces what Jim was saying about the uneven implementation of services and why we're really looking at quality and how to improve quality through a standardized set of regulations to follow. So go ahead and advance the slide again, Jennifer. So again, looking to just improve level 1 as a service, what we hope to do through this project is learn from others, looking at what surrounding states are doing with level 1 supervision, getting information from other stakeholders like our BCs working in Indiana, psychologists. We're partnering with the Indiana Psychological Association, IPA, and also case managers, because I think they're an important stakeholder in this as well, just how people come into contact with services. So we'll look at developing some focus groups and then pilot clinics across the state, where a lot of BCs who may only have experience with that low quality supervision, getting them face to face with a level 1 supervisor and seeing what their impressions are, what are the outcomes, does that lead to better behavioral supports for the individuals they're serving, and then eventually developing a curriculum based on our findings, and then recruiting and training new level 1 providers. And then the final step is, hopefully we can present this to DDARS and it can lead to some changes in the regulations. Yeah. And we can skip this one because we're taking questions at the end. So again, here's our information. We have a QR code too. I believe that's just to our website though. So if you want to learn more about who we are and what we do, feel free to check that out. And again, I'll end by just kind of echoing what Kelly said. We appreciate this opportunity to take a closer look at this service, and just the support from BEADS. Really appreciate that.
Thanks, Brian and Jim. I think I need to promote Dr. Trivedi. Okay, Dr. Trivedi, you should have control. I will go ahead and give you control of your slides, or you can just go ahead and say next, and I will do it. You should have control of your mic and your video now.
Okay, can you hear me now?
Yes.
Okay, great. Let me just see. Thank you very much. And I'll just have you advance them when I'm ready then. Thanks, Jennifer. I apologize. I have been coughing, so maybe interrupted by periodic coughs here, but thank you all for the opportunity. I'm just going to go ahead and present our project here and kind of give a little bit of an overview of what we do and who we are and what we hope to achieve during this project phase. Our goal really is to help achieve superior healthcare for vulnerable individuals, specifically those individuals with IDD, and we happen to use telehealth to deliver that care. You can go to the next slide. I think I can control it as well. So just a little bit of background about our organization called StationMD, founded by emergency medicine physicians. I'm an ER physician myself. We are all board certified and all licensed in Indiana, and we do provide some services right now, but our solution is really to allow individuals to stay in their home setting and get health care for things that they need and keep them out of the emergency department urgent care whenever possible. One thing to emphasize is that all of our clinicians in this project are specially trained to treat this population. They go through a specialized curriculum to understand not just the clinical needs, but also the non-clinical. I feel very comfortable saying this, that most doctors really don't know how to care for this population. I was one of them myself. They don't understand the clinical nuances. Forget about the non-clinical. I think the average physician has no idea what a DSP is, or a BCBA, or a group home dynamic. And I think that's critical to provide optimal care. And we're hoping that through this project that we're going to show the impact, number one, on the individual and their quality of life, number two, on the support staff and agencies. But interestingly enough, there is a tremendous ROI because we're hoping to save a lot of emergency department visits, urgent care visits, hospitalizations. We are in many other states, covering many other lives, and we are looking to expand this solution into Indiana. These are just some of the organizations, including INARF, that we are members of, that speak on this solution, because I do think it's important to be advocates, and we're hoping that if this project is successful, that we can expand on that footprint in Indiana, but also bring it to other individuals in other states. So here is the gist of the issue here, and why does this population use the ER urgent care more frequently than others? And I'm probably preaching the choir here on this call, but outside of the individual's underlying IDD, they have other comorbidities which make them high risk, whether that's pulmonary or GI or behavioral. And even if an individual in the state has a primary care doctor, that physician isn't always available. They may not have the same technology we do, and by default, they get sent to the emergency department or urgent care. And the goal is, through this project, that we would provide that care in the least disruptive, most stable environment, and that is, of course, the individual's home setting, whether it's a group home or whether it's their own home. And we're going to work closely with the division to identify individuals locations in the state and agencies that we feel would benefit from this, number one, but also where we would have the biggest impact. The other thing I'll mention is there's just a lack of access to medical care. This is not relegated to Indiana. It's not relegated to rural settings, but everywhere. Trying to find a clinician that understands the needs of the individual that make it easy to get to is tough. And lastly, I will say that many agencies are burdened with well-intentioned regulations that have unintended consequences, that they need to see a physician or a nurse if something transpires, if there's a med miss, if there's a fall. And many of these, which I'll touch on a little bit later in the presentation, can be handled via telehealth in the home, and they don't really need to be sent out. As an ER physician, I can tell you that, individuals coming to the ER, it's frightening for anyone, but for this population, it's especially frightening. We call it the trauma of transport, just getting them there. And it's a big burden for agencies specifically, because we know the problems with agencies are staffing. And now you have to take an individual to outside setting or doctor's office, urgent care, ER, and they just don't have the staff. They have to backfill. For families, of course, it's also very traumatic because a lot of individuals have to leave work or skip school, and it's very disruptive to the individual's routine. Our hope is, and one of the things we'll be measuring in this is how we can avoid those ED visits, comparing prior to using us and now using us, how many of those visits are avoided, how many hospitalizations are avoided. And then we will, of course, also be surveying individuals and see if they like it, and also hopefully be able to get some Medicaid claims data to show, we save X amount of dollars on transportation, ED visits, hospitalizations. I put in here mismedication because in my years in the ER, many times I've had individuals come simply for a med refill. And that's really not a place to go to get your medication refilled, or a sore throat or a cough or a minor issue. So, you have this combination of unspecialized care. As I mentioned, as an ER doc, I would see the individual. I really didn't know their nuanced issues. By default, I would order tons of tests. They wait hours. It really is suboptimal care and disruptive to the individual and the staff. But of course, it's expensive. So this is what we hope to address, these 2 points, and how we can, number one, elevate the quality of care, but also show that this investment in this project has a tremendous opportunity to be expanded, and show the savings to the state. So real quickly, switching gears to telehealth, I think if there's any silver lining to the pandemic, telehealth has proven itself as a viable means of delivering care. You may have it yourself through your own plan. And our hope is to show that what we believe is the value of telehealth for this population is even greater, because of the things I've mentioned. They don't have access to good care. They don't have access to clinicians who understand them. They have issues of mobility. They rely on a short staff or family members to take them. I will emphasize, obviously, this is not for everything, but for many things, I do not look at this as a substitute, but I look at this as superior care, because they're in their own home. They're seeing clinicians who really understand their needs. And we hope to prove that through this project. So real quickly, on the left of the problem, the right solution, the access issue. There's no geographic impediments. We're going to focus on specific areas throughout the state that need that care. The suboptimal care, I've already mentioned, our physicians go through the training. We also are going to have access to medical records. We are also available 24 hours a day, 7 days a week during the life of this project. And then we also provide full documentation of all of our encounters to the agency or the family and through the primary care doctor. We're not there to replace a primary care doctor, but if I see an individual on Wednesday night, I will send my note and documentation to the primary care doc, so they have that and they're kept aware of what's going on. This is just a screenshot of the portal that we are going to be using, who called, when they called, the time of day, all the physician's notes, everything's in there. I want to emphasize that we are looking to pick, I believe it's 150 individuals, and this is going to be a resource, 24/7 resource, not just for emergent issues, but any medical question that the individual, the DSP, the family, the support staff have. They need a med refill. If they have a question, Constipation in this population turns into bowel obstruction. UTI turns into urosepsis. So we want to be called, and we will be available for those calls. Lastly, these are traditional outcomes that we've seen, and we're hoping to replicate many of these in the state. We're more like 92%, meaning 92% of the calls we get, we're able to keep people out of the ER urgent care. These are some of the reasons we get called for: cough, seizure, fall, cellulitis, pink eye, COVID, still vomiting. The blue are the ones that we've traditionally been able to keep in place. The gray are the ones we're going to send out. We're also, during the life of this project, anytime an individual gets sent out, we will call the ER in advance or urgent care and let them know why they're coming, in the hopes of avoiding unnecessary testing. It really is the gold standard when a doctor to doctor calls that I am just sending this individual for an x-ray of the hand. He doesn't need a CAT scan or blood work, and please don't make them wait in the waiting room forever. It's been very well received, and we hope that will not only improve the quality of life of the individual and wasted time in the ER, but also unnecessary testing and turnaround time. Lastly, we did some surveys. We're hoping to also continue this, where the satisfaction surveys that we've developed are geared towards individuals and DSPs. And there's also outcome for the agencies that we partner with, because they're saving overtime costs, they are saving transportation costs. There's an ROI on that end as well. And these are just some of the agencies. Lastly, I will say that we are partnering with Benchmark Human Services on identifying several complex individuals where, in addition to our 24/7 telehealth, we are going to do some wraparound services where there's actually boots on the ground, where we will tap into their expertise, some virtual, some real, where these are the most complex individuals that are in and out of facilities, in and out of institutions, that need behavioral supports. They maybe need more intense in-person supports, in addition to the 24/7 health supports. That part of this is about 20% of our project, and that's a work in progress, because we really need to tailor those services based on the needs of the individuals that we and BEADS identify that we want to serve. So that is about 20% of this project, and we're looking forward to partnering with them and other agencies. I guess lastly, I will say that if you on this call or have any ideas or suggestions for who agency or families or individuals would benefit from something like this, we're going to work closely with the agency, but also INARF and some other agencies that we've reached out to identify those 150 individuals that will be getting this service and solution. So thank you.
Thanks, Dr. Trivedi. We have one more. Casey, I will give you control of the slides, or I can go ahead and do that for you. It's up to you.
Okay, thank you. I should be able to do it. We'll see how it goes. Okay. I don't know if I can motor plan this, but I will do my best. All right. Well, first of all, I'm Casey DePriest. I'm the founder of Optimal Access, formerly Optimal Rhythms, if you've heard of that before. I'm also head of school of our Access Academy, which is a school that is specifically designed for non-speaking or unreliably speaking autistic students, in which they have access to a full general ed academic experience with the supports and accommodations that they require. We are so excited to be a part of what's happening within Indiana and to have an opportunity to do our project. It's been something that's been on our hearts and minds for a long time. And so again, I'll echo that how appreciative we are of being given this opportunity to make a difference and to just try to quantify what we're really seeing in communities and among this population that we have identified to serve. So I'm going to, let's see here. There we go. So just real quick, our mission statement at Optimal Access is that we're committed to supporting autistic individuals to achieve their maximum potential. And that's really where it's at. It's just, how do we do that? And so what we've learned is that we can do that by improved understanding of the stakeholders that support or work with these individuals. And then an interdependence, an attitude of interdependence, or an expectation of interdependence within our communities. We utilize this hashtag. So if you're interested in more of what we've done or what we do or what we find important, you can always look at this hashtag, Rethink Autism. And here's our one pager. Most of this information is supported in the other slides that we have. So just know that we have this. This will be available on the website if you're interested in more information about our project. The goal of my presentation today is really to outline the need, because we find that when we talk to people, people just are not aware of how many non-speaking or unreliably speaking or minimally speaking individuals are served within waiver services, and how their lives might be impacted by that. And a lot of the things that we do within our organization are informed by neuroscience as well as the lived experience of these individuals. And so they are very actively involved in this project, and we're really excited to bring their voices forward to allow the state and other stakeholders to understand what challenges they face in a community in which they don't have support for communication. So our overarching goal for the Rethinking Autism Support Training Project is to improve the lives of non-speaking individuals who receive DSP support as part of their Medicaid waiver budget. And we want to do that by implementing accessible, engaging, relevant, and cost-effective training modules for caregivers and all members of the IST. We also want to do that with content that is grounded in neuroscience, that is evidence-based and informed and approved by non-speaking adults who utilize these services. Our rationale for the IPP was that we want to improve the lives of non-speaking individuals, that involves impacting change within the whole ecosystem. We don't want to just focus on changing behavior of one person. We really want to look at the whole experience that they face every single day. And how are they understood? How do people recognize what their true needs are? How do you recognize why they're not communicating in a traditional way or utilizing speech effectively? And so we want to look at the whole system, look at everybody who is interacting with them, and make sure that there's a universal understanding, hopefully informed by that person once they have access to communication. We want DSPs and IST team members and family to play crucial roles in the lives of these individuals, and that, by default, that's part of the intended audience for this initiative. So we recognize that those are the boots on the ground that have potential to change the forecast for these individuals. And so by them having the best information and the best training, they're going to be in a position to support people who do indeed need support. We are looking at shifting perceptions and understanding of these supportive stakeholders and what they will play as an important role in impacting the quality of life that is achievable for non-speaking individuals receiving home and community-based services. So just again, a little bit about why. Neuroscience recently revealed that up to 87% of autistic individuals experience some level of motor disability, which we refer to as apraxia, and it's experienced as a brain-body disconnect. So if you kind of imagine that you're sitting here today and your mouth is taped and your hands are tied behind your back, how would you participate if asked a question? How would you let us know if you had a question? How would you let us know if you had a need? So those are things to consider, and not everybody is affected in the same way, but when we think about the spectrum, there's some suspicion that the spectrum is actually a level of impact of their brain-body connection. So just a little bit different perspective on that. We want to understand the lived experience of these individuals. So again, it's important to understand that an estimated 40% of all autistic individuals or people with that diagnosis are non-speaking. And we quantify non-speaking as non-speaking, unreliably speaking, and minimally speaking. And that equates to 31 million people worldwide. So we're still working on the specific numbers of Indiana. The goalpost on that keeps changing a little bit, but you can imagine that this is a huge need if this is indeed true, and this is what the research is showing us. The unfortunate thing is that only a small fraction of these non-speaking individuals have been taught how to communicate reliably outside of speech when speech doesn't work for them. So we want to encourage everyone to remember that not being able to speak is really not the same as having nothing to say. We believe that these individuals that we're serving in home and community-based services that are unable to rely on speech still have a lot to say and should be informing their good life. So as we have developed our services over the years, for almost 10 years now at Optimal Access, we've come to understand that speech is a motor process. It's not something that is representative of someone's intellectual function or their cognitive ability. So speech is motor and language is cognitive. They're really not the same. They're not processed in the same area of the brain. They're not learned and developed the same way. Oftentimes when development happens traditionally or typically, those things happen in partnership. But it's perfectly, it's totally possible for someone to have a lot of language ability and to be developing language in a very developmentally appropriate way, but not to have the motor ability to express that. And so why do we want to do a training? We want to do a training because we realize that people don't know what they don't know. And when we know better, we do better. As a therapist, I worked for almost 15 years without any of this information that I'm sharing with you right now. So I know what it's like to not have good information and to think I do. And I know what it's like to work really, really hard and just kind of keep coming against the same outcomes and not knowing why. And I can tell you that since we've changed our paradigm and relied more on the neuroscience instead of more of a behavioral approach or developmental approach, we've had tremendous differences and improvements in our outcomes. So we want to listen to actually autistic people to understand the lived experiences of those we aim to support and protect. So I've got just a real quick video that I would like to share with you. This video was written and contributed to by non-speaking people, and I think that it's a pretty powerful way for you to hear their voice. So if you don't mind, we'll start here. Jennifer, I might need your help to get this going.
Content warning. This film contains a description of the experience of being restrained. This section of the film has a warning immediately before it and is filmed in black and white to make it easy to skip past if you decide not to watch it.
Hi, I am Grant Blasco, a college-bound high school senior.
My name is Jared Zimmerman. I communicate by typing on an iPad.
My name is Endeavor, and I'm a multimodal communicator.
Hi, I'm Isaiah Graywall from Canada. I type and spell to communicate.
We're all autistic and we're unable to rely on speech to be understood. Most of us are non-speaking. Some of us can speak a little or from time to time. People have a lot to say about us. They write stories and biographies. They produce plays and make movies about us, but they are not listening to us.
Just because I cannot speak does not mean I don't hear. I hear everything people say to me or about me. I may not show understanding in my face, but I know and understand. Not a word said escapes my so strong ears.
We may be non-speaking and need help with many things, but that doesn't mean we can't contribute to a book, a play, or a movie. If you always leave us out, people think we are not able to participate. That's why most people don't realize that we have a contribution to make. Include us. and you will see that we have so much to give.
To anyone who wishes to represent non-speaking people, I ask that you communicate with us directly. Misrepresentation of non-speaking people leaves us more vulnerable to abuse.
I should not be left out of conversations or presumed incompetent, simply because I don't rely on spoken language.
There needs to be more representation of diverse autistic identities.
The media often shapes how we view ourselves and how others around us view and esteem our place in society. When there is lack of representation or improper representation, it directly feeds into the internalization of stigma, where your membership in a group is the very cause of your negative self-esteem, feelings of inferiority, and even feelings of self-hatred.
If your story says there's no hope, people may not realize how many of us can share solutions about how to support non-speaking children and adults. People who write about us tell the world what they think is best. Other people who follow their example could hurt us rather than help us. To be treated like a child just because you can't communicate in the usual ways is humiliating and traumatic.
The way to demean me is to speak to me as if I am a baby.
I don't like people talking about me like I am not there.
Some books and movies include scenes of restraint. These can be painful to watch. You may want to fast forward the next few seconds that are in black and white, where an autistic survivor talks about his experiences with prone restraint.
Every escalation was blamed 100% on me, no matter if they had just done something illegal to me, cornered me, taunted me, taken something I needed, whatever. Your body is tensing up. Your breathing tightens up. Your fists want to clench. You can feel your body betraying you. You can fight or fold. It's up to you. You are hitting the ground either way. You are face down on the floor. You may relax, you may beg, you may play dead. None of it works. If you show pain, they will show you more pain. I thought I was suffocating and I called out to say so, and they laughed. The way people who use restraint talk, you might think it is an almost surgical procedure. It's not. It is a fight with a predetermined winner, who isn't you.
How do we get it right? Consult non-speaking autists from the start and add key points throughout your project. Read our blogs and books. Watch our movies and videos. Learn about our lives.
If you have a voice, you can use it to help bring dignity back for the members of the more marginalized autistics. Let's change the plot lines and the narratives around non-speaking autistics so more and more are allowed to be visible in society and avail of opportunities in all kinds of areas. Then we will truly see more and more non-speaking autistic actors who will be able to provide us with more positive and authentic representations.
Ask us. Listen to us. Nothing about us without us.
Okay, so that is the approach that we are taking with this project, that we cannot accurately inform the state or each other or stakeholders if we're not really paying attention to the lived experience of these individuals. For us, ACCESS stands for Assuming Competence Can Ensure Student Success. And I'm reminded of Kelly Hartman's presentation, fabulous presentation, by the way. That was a mandatory presentation for providers about presuming competence. And I think that's kind of where this starts, is we really need to take a look at the lens by which we look at non-speaking people or people who have complex communication and motor and sensory challenges within our caseloads or within our service area, and think about how do we provide them access with the things that they need to be fully included and to have a good life. So our expected outcomes based on the work that we have done previously within our organization, within our programs, is that when we presume competence and make communication accessible, even to a small degree, we see increased engagement, sustained attention, communication and understanding of needs, self-initiation, confidence, emotional regulation, participation in their PCISP or goals development and satisfaction. So a movement towards a good life. And what we see decrease is disruptive behaviors, emotional dysregulation, aggressive behaviors, frequency of redirections, misunderstandings, incident reports, and staff turnover. So those are some of the things that we're targeting in this project. So I'm happy to answer any questions. Here's my contact information. We have a great team moving forward with this, and we are partnering with SERS. So we have identified one provider that we will be working with. At this point, we plan to target about 15 non-speaking individuals who are provided services within the SERS organization, and all the different individuals that support them each day. So thank you so much for the opportunity.
Thanks, Casey. I just want to finish this up before we get to questions with a reminder that all of this is to support DDAR's mission, which is that all people are empowered to live, love, learn, work, play, and pursue their dreams. If you've got questions, they've been sharing their contact information. You can certainly reach out to them directly. But if you have general questions, you can feel free to reach out to us at beadshelp@fssa.in.gov, or typically Jessica Harlan York is the one who's hosting these, and you can reach out to her as really the lead at DDARS around these projects. So I will have Alina help me if there are any questions that we received in the question and answer, or if there's anybody on who hasn't put one in the question and answer box, this is your chance.
So one question that came through was someone noting that these are amazing projects and wanting to clarify how a person can sign up to participate or be considered for participation for each of the projects. I know that Casey, you just noted that it's through your connection with SERS that folks are being identified for work in your project. I also know that Kelly, you provided a QR code that can tell more information about getting information about your projects, and wonder if Kelly, Jim, and Brian, and also Dr. Trivedi could quickly speak to how folks are being identified to participate in these projects.
I can let you know from our perspective, we are going to reach out to providers with a survey coming up, providers, stakeholders, individuals, families, guardians, however we can reach people. We're sending out a broad survey that will also allow people to give an opportunity, they will give them an opportunity to say they'd like to participate. Our plan is to go about doing it with different kinds of agencies. For example, community-based not-for-profit, small provider who might be newer, large provider, and then to cover all geographies in the state, because we want to have a statewide perspective.
Yeah, for Kestrel Behavioral Health, we're also going to do some surveying. I put in the chat that anyone who's interested can go log into our website at kestrelbh.com. That was also what the QR code was on ours, if you happen to take a snapshot of it, and go to the contact page, and that sends an email to me and to Brian, and I'll just write your name down and make sure that you get on a list. And if you're interested in our project or whatever, we'll just keep you kind of on that list. But we do plan to also survey in a couple different areas. NABC is one of them. I know Kelly, we talked about that earlier. I think both of us are going to do that.
And this is Malik from StationMD. We are going to work with BDDS as well as INARF and focus on areas where we feel there is a need, whether there's a lack of access issues that's greater than other areas. We're going to focus on some parts of the state where we have worked with other agencies and feel like that there's more of an impact. But we're also open to suggestions if someone wants to reach out to us through our website or directly to me that wants this service and solution to be part of the project. Happy to do that as well. And lastly, we are going to also work with one of our partners, which is Benchmark, as I mentioned, to see if they have suggestions. They've had a presence in the state for some time and are very well connected. So, thanks.
And I want everyone to know we're excited about all of these too, but with limitations in funding, sorry, my tornado siren's going off. And also, we had to remind all of them that these are pilot projects. It's not that any of them didn't want to serve everybody and as many people as possible, but these are pilot projects, and so we really want to test it, and then the hope is that some of these will continue. You can always reach out to Jessica as well if you're trying to get some information about the projects. Some of them do have specific eligibility because of, again, the nature of their particular grant. Is there anything else, Alina?
No, that was the only question. Thank you, everybody.
All right, if you think of things later, feel free to reach out to the organizations directly or to Beads Help or to Jessica. And thank you so much for your time today. This recording will be posted soon, probably in the next week or two. Thank you.
Thank you.
Thanks, everyone.
Thank you, everyone.
Bye-bye.
Bye.